Morning and welcome to Our Community, Our Health, a town hall series to share ideas about health prevention and treatments that impact our community. I am Dr. Lisa Spiegel. I am an associate professor at the University of Florida, Department of Surgery. I'm the section chief of breast surgery and the clinical director of the Breast Center, and I am so delighted to be here today to be the moderator of the town hall. Today, we will be focused on a discussion about breast cancer, and we will talk to some amazing experts with Dr. Lakeisha Cousin, Tawanda Williams, and Latrina Macy. And I'm going to have each of them introduce themselves to get started.
Thank you. Good morning, everyone. My name is Dr. Lakeisha Cousin. I'm an assistant professor at the University of Florida College of Nursing. I'm also a member of the UF Health Cancer Center, and my research examines how stress, inflammation, and positive psychology can influence health outcomes and behaviors among breast cancer survivors. Excited to be here.
Good morning, everyone. My name is Latrina Macy. I am the Assistant Director of Outreach and Education in the Office of Community Outreach and Engagement at the Cancer Center. And I am here today and so privileged, and thank you to Our Community, Our Health team for the invitation. But a lot of my background is in community work. And so a lot of the work that we do is making sure that we're boots on the ground, sharing information and resources to the community.
Wonderful. Welcome. And Tawanda will be joining us likely a little bit later during the event. So this is how all of our listeners can become engaged in the conversation. There'll be a Q&A button on the bottom of your screen. And if you just click on the Q&A button, then you can send all your questions throughout the town hall. I'm going to be tracking them throughout the talks for our panelists. And then at the end, we will go ahead and address some of the questions that have been sent around. In the beginning, just to get things kind of up and going, we're going to start with a few pre-town hall questions, really to gauge your interest and knowledge of today's presentation. And these are going to appear, as you can see right now, screen as a poll. So take a moment to answer these questions, and we will also ask these questions at the end of the town hall. So we'll go ahead and answer those questions, and then I will move on to present Dr. Cousin, who will start off our event.
Thank you. I'll go ahead and share my screen.
Great.
Okay. So go ahead and get started. So good morning, everyone. It is indeed a pleasure to participate in the virtual town hall and briefly talk about my study, Grateful Strides Towards Physical Health and Well-Being Among Black Breast Cancer Survivors. And so I always enjoyed sharing this slide just to talk about, some of the advancements that we have in earlier detection and treatment, but we've had a decline in breast cancer death rates, but not all women have benefited equally. And so I share this chart because it shows a trend in breast cancer mortality by race and ethnicity. And so when we look at in the mid-70s, breast cancer death rates were very similar among or between white and Black women. But, we've had a rapid uptake in screenings and advancements in treatment, largely due to Breast Cancer Awareness Month that we're living in right now in October. But we start to see a disparity between white and Black women in the late 80s. And so as of this year in 2023, we still have cancer death rates that are still 40% higher among Black women than white women. And so when we look at these disparities, it lies in examining social determinants of health. And so we really need to pay attention on how social factors, especially systemic racism over time, may have contributed to excessive breast cancer mortality, often experienced by Black women. And so in one of my recent articles, I discussed the impact of social determinants of health and care for Black breast cancer survivors. For example, Black women experience higher rates of cardiotoxicity and cardiovascular disease-related comorbidities than white women. And this is often due to us having an earlier onset of cardiovascular disease risk factors and metabolic syndrome. And so to contribute to eliminating some of these racial and ethnic breast cancer disparities, we really need to start to understand the Black woman's lived experience of racism and a lot of this cumulative stress of living with disproportionate burden of social and environmental threats. So today I'll dive in a little bit further in some of the quantitative and qualitative evidence to support this. And so I always love talking about cultural frameworks because it truly helps to capture the lived experience. And so a culturally derived framework that I use a lot in my research, also known as the Superwoman Schema by Dr. Cheryl Giscombe, she developed and theorized a theoretical framework that looks at this unique race and gender specific experiences that forced this stoic disposition of unbreakable strength among Black women. And so it's typically surrounded or centered on 5 traits. So the first trait, maintaining unwavering strength, 2, suppressing emotion, demonstrating this self-reliance, just trying to succeed despite all obstacles that we may face in our lives, and lastly, placing a need of others before themselves. But I'm really, really interested in looking at the spiritual values that impact quality of life among breast cancer survivors. And so as you can see through evidence, Black breast cancer survivors have these unique stressors, right, that impact cancer and cardiovascular risk. And so they may have these higher levels of stress from all of these life events that are associated or affiliated with the Superwoman Schema, in which we may feel the need to encourage silence around all of the stress that we're living with and having to take care of not only ourselves, but having to take care of others. And so sometimes we like to put ourselves, on the back burner. And when we do this, this leads to increased stress, which leads to weight gain, inflammation, and this higher risk of cardiometabolic syndrome, which is a large reason for disparities between white and Black women. And so when we're living with obesity, it promotes inflammation. And we also have increased levels of inflammatory biomarkers that it can impact our overall immune health. And so we really need to take a look at some of these culturally tailored frameworks like the Superwoman Schema so that we're able to identify and form recommendations so that we can improve quality of life for Black breast cancer survivors. And so I'd like to share a recent qualitative study that was published last year. They looked at 7 focus groups, about 30 Black women in the Midwest region. And so there were 4 common themes in these interviews. And the first thing is that caregiving roles, they have support and they have challenges because as women, we have this traditional gender role that position ourselves to take more of a caregiving role in our families. And of course, that motivates us during survivorship, but it also can be a challenge in managing health. And as you can see here, they talk about the strong Black woman construct. It's inherent in survivorship experiences. And so we may know that there could be protective health benefits in being strong and resilient, but it also can worsen health risk and the obligation to help others. So more importantly, we have to start to understand the intersectionality that impacts survivorship because breast cancer survivors live at this intersection of race, social class, and gender oppression. And so this makes survivorship for Black women more challenging. And so I wanted to highlight 2 quotes from this qualitative work to illustrate the lived experience. And so Black women can draw upon a strength identity that continues throughout their lives. And so a lot of times family members often don't know that they have breast cancer. When you look at the last quote, for example, I didn't want to hurt them. I didn't tell anybody in the family because I was afraid it would devastate them. And I lived with it for more than a year. And when I did tell them, that devastated them even more. And so whenever I look at this quote, I vividly remember my grandmother who lived with breast cancer. She also lived with heart disease. And I had never seen her complain, not one time, about having any pain or suffering. She always displayed this beautiful, strong Black woman, but I know that she was probably dealing with many difficulties on the inside. And still, she had to carry this caregiving role in putting herself before others. So self-silencing her pain, like many of our breast cancer survivors daily. So now that we can understand the problem behind breast cancer disparities because of this intersectionality that I talked about, we have to understand and translate the knowledge about these cultural frameworks so that we can promote health for our women who are living in the survivorship phase. And so my work examines these protective factors to improve psychosocial distress. I also like to look at physical health outcomes to reduce cardiometabolic risk among these women. And so we have risk and protective factors, right? There's genetic factors, there's lifestyle factors, and environmental factors. You know, as a researcher, I understand that genetic factors, we can't change that, but we can find ways to help to change behaviors and lifestyle management to reduce the risk of cardiovascular disease and cancer. And so some important factors to look at include physical activity, maintaining a healthy body weight, and looking at some of these psychosocial factors to help promote health behaviors and envision an upward spiral toward a healthier lifestyle. And so historically, Black women have used spirituality to inspire hope when dealing with hardships. And so my grandfather was a pastor in a Black church in my hometown of St. Petersburg, Florida. I personally witnessed sick members use the power of spirituality and gratitude to help them cope, to help them improve quality of life. And so some coping mechanisms include prayer, social support, journaling to express emotions. For example, some churches have Bible journaling clubs to elicit social support. And so among Black breast cancer survivors, spiritual well-being is a primary coping mechanism during all treatment and survivorship phases. And so I'm interested in cultivating these protective factors to help change health behaviors like physical activity and improve immune health. For example, having a gratitude trait and spiritual well-being have been related to improved mood, higher self-efficacy, lower inflammatory biomarkers and other clinical populations. But what do we know about Black breast cancer survivors? A lot of this work has not been done. And so I aim to look at how it impacts their mental and physical health outcomes. And so whenever I talk about my work in gratitude, I either get people who look at me sideways or they're like, okay, what are you trying to do again? So I like to break down the definition of what gratitude is. And so I'm really interested in this two-step information of processing the concept. So first, you have to affirm goodness. And the second is recognition, right? So first, you're affirming that there is something good in life. We're saying yes to life. My life has some good things, and life itself is good in many ways. But we know in life, there are problems, there's flaws, but we do have good things that we need to recognize and celebrate. For example, with many of our patients, there's a second chance at life after surgery. There's a second chance at life after overcoming a chronic illness and feeling better. And so that recognition is important in my work because it leads us to understand that there are sources outside of ourselves that we don't take credit for. And a lot of times in the Black community, we say that that's God, or it could be forces outside of ourselves that are doing things for us that we cannot do for ourselves, which is also known as spiritual well-being. And that results in feeling gratitude. And so that recognition is important because it leads to behavior changes, such as exercise readiness, physical activity, or even medication adherence. And so regarding gratitude research among cancer survivors, it's been conducted in many studies among white cancer populations. For example, there are studies that include gratitude journaling. There's one, for example, every day for 2 weeks, 42 women with breast cancer described their psychological well-being, their social support, and coping strategies. And women who were in the intervention condition reported that they felt, or why they felt grateful that day. And just writing down or listing feelings of gratitude led to higher levels of daily psychological functioning. They had greater perceived support and also greater use of adaptive coping strategies. So these results overall in other populations suggest that gratitude interventions can improve the lives of cancer patients, but there's still that gap in understanding the mechanism behind the gratitude's link with physical health, especially with inflammatory biomarkers and physical activity. And so I'm very excited to talk about, my first clinical trial in Grateful Strides Towards Physical Activity and Wellbeing for breast cancer survivors. The trial just ended this summer. So although I don't have my full results yet, I do have some small preliminary data just to briefly share. And so my research question asked, does gratitude impact mental and physical health? Pretty straightforward. I want to assess the effects of gratitude journaling on physical activity, well-being, and inflammatory biomarkers. And so I looked at certain biomarkers like TNF-alpha, interleukin-6, GDF-15, and C-reactive protein. And so it's really interested in certain biomarkers like GDF-15 because it's a stress-responsive cytokine, and it has a role in regulating inflammatory pathways as well, and also has some connection with cardiovascular disease and cancer. And also I was very excited to look at the cultural roles of Black women by examining the Superwoman schema that I talked about earlier. And so my research aims are basically testing if my randomized control trial using 2 groups will work over 8 weeks. So I wanted to look at the differences between gratitude journaling compared to an attention control group, which used general memory journaling. And I examined some additional variables like gratitude traits, spiritual well-being, psychological distress, and also looking at exercise readiness, and also the Superwoman schema. And of course, inflammatory biomarkers that I talked about earlier from baseline to post-intervention. And so my inclusion criteria, I just included Black women who had a history of breast cancer, and I excluded those who regularly meditated or used gratitude practices in their daily lives. So looking at my proposed intervention, I wanted to combine the practice of gratitude with that of goal setting because I want to see how it further increases adherence to health behaviors because no similar studies have been conducted among Black breast cancer survivors. And so prior work in other clinical trials, I found that pairing the use of optimism and gratitude with education and goal setting can lead to more physical activity and fewer hospital readmissions, and also improve levels of inflammatory biomarkers. And so a novel component that I'm adding is the culturally tailored framework that incorporates the Superwoman schema, and also to understand if there are benefits or liabilities using this framework. And I hope that using all of these variables can help enhance my future research on psychological stress among these women. And so the feasibility design was broken into 2 groups, and I built on original gratitude journaling interventions already in the literature. And I paired the use of goal setting and physical activity education. And just 2 examples here of some of the journal prompts that I used in each group. And so my primary outcome, I looked at feasibility and acceptability of the intervention. And the second outcome looked at the biomarkers that I talked about earlier. I wanted to see the preliminary efficacy of my intervention on these outcomes. And so I was able to enroll 26 Black women. Their mean age was close to 65 years of age. As you can see here, 96% of the participants were classified as overweight or obese. I lost 7 of my women to follow-up due to the work schedules and transportation. But 73% completed baseline and post-intervention, and 86% of the women actually were mostly satisfied or very satisfied with the intervention. And so I do have additional data and biomarker samples that are currently being analyzed. And so my study will serve as a basis for a future larger randomized control trial to test the efficacy of a multidisciplinary psychosocial protective intervention. And of course, I want to still incorporate biological mechanisms. And so I set a very lofty goal for myself. I submitted a grant proposal to the National Cancer Institute for the Cancer Moonshot grant proposal this summer. So please pray that the work will at least be discussed. I'm not holding my breath, but hey, I got to aim high. And so my ultimate long-term goal is to help prevent and control breast cancer among Black women. And I also want to look at social determinants of health among underserved communities. And so in conclusion, Black breast cancer survivors, we face many challenges compared to white counterparts doing survivorship, but we have to understand the importance of breaking the silence on the Superwoman schema and any other culturally tailored frameworks to increase knowledge about certain cultures, right? We have to find more innovative ways to eliminate breast cancer disparities. For me, in my work, I look at gratitude, I look at spiritual well-being as protective factors. And hopefully, I hope to make a difference among my population. And my last slide, I just wanted to invite everyone tomorrow at Spring Hill Baptist Church, Eastside Gainesville, where we can further discuss this conversation. We have a group of amazing research scientists, including Dr. Spiegel is going to be there to talk. And we just invite everyone to attend. So thank you so much for your time and listening to my research interest. I'll stop sharing.
Okay, great. Wonderful. I mean, that was just such a fantastic talk, a really difficult talk to talk about, right? Something to discuss, and we can talk a little bit more in the Q&A, but this is real, and something that really we need to focus on and shed light on is really disparities in outcomes based on racial disparities, right? So I'm excited to get involved in the Q&A. And again, we should always have great goals and aim as high as we can, right? So I'll send prayers your way. All right, our next speaker, we're going to move to Latrina Massey and get her going with her talk. So excited to hear what you have to say for us today.
All right, I'm sharing my slides. Good morning, everyone. Again, my name is Latrina Massey. I want to, again, thank you all for this opportunity to be a part of this discussion. This is a very crucial topic that I know our office, the COE, is finding innovative ways to impact. And so I would be remiss if I did not also acknowledge the team that works really hard behind the scenes to make all this happen. So their collective commitment really fuels our progress and elevates our impact. And I would like to share a picture of those individuals here. This is the Office of Community Outreach and Engagement. And we are a part of the Cancer Center, and we are tasked with reducing the burden of cancer in our 23 county catchment area. And so how we do this, we look at approaches from prevention to survivorship. We do this by partnering with local community organizations, members, health systems, patients, and families. We bring outreach, we bring access, education, increase access to evidence-based cancer screening services, and to address those catchment area needs and those disparities. For the purpose of today's discussion, I'd like to share information specifically around our work with breast cancer. We will explore some of the challenges and disparities that exist in our catchment area, the strategies and the collaborative efforts that we've undertaken, and some of the impact that we've made in our vision for the future. So moving right into, as Dr. Cousins had mentioned about the disparities, that there is still a gap between, Black women and white women, and how that still exists, even with the enhancements in care and treatments, there are still disparities. There's still a gap that exists. And so the Office of COE and our project Continuity, which is one of our flagship programs, was designed and developed to respond to those disparities that we find in our catchment area. One of our major barriers, as we all know and have heard, is access, right? So getting people access will allow earlier detection, will then also impact outcomes. And so this access has this downstream or a cascade of consequences that exist if that's not the first step that is established and made. So access is very crucial to making sure that women are getting the services that they need and in a timely fashion. And so this is just the slide that presents that information for us and how we use access as the first place that we attack or address, rather. We use a very collaborative approach in that we don't do this alone. Project Continuity has a wide range of community organizations that we work with. We work with clinical partners. We work with the Florida Department of Health to all make this a reality. And so Project Continuity is our, as I mentioned, our flagship project, but mammography after Sunday service is kind of the gate for all of this finding of the women who are in need of services, and also the hub for education. This is ran by Pamela Burnett. She is a breast cancer survivor, and she works very diligently to make sure across the state of Florida that women are having that are in need have access to the services. Women are able to receive mammography services through the breast and cervical early detection program. So our community clinical navigators, who are a part of our Project Continuity team, work really, really hard to, when those women are identified, they're working to make sure that these women eligibility applications are submitted, making sure all the documentation that's necessary for those applications to be submitted are done. The navigators really have a hands-on approach with every encounter, with every patient. They strive to make sure that, no patient slips through the cracks, that everything that's needed, even if it requires something else. So granted, today we're talking about mammography, we're talking about breast cancer, but our community clinical navigation team will also assess whether a patient needs other services, right? Maybe they need a fit test, maybe they need a pap smear, whatever it is, to make that as comprehensive or as bundled as they can. We establish patients with our clinical partner, which is Mobile Outreach Clinic, and they provide and ensure these patients have what they need. And then we have our wonderful partner, Rural Women's Health Project. She and her team, Robin Louie, work really, really hard to make sure that when there are needs, especially in our Latino community, that they are being brought to these events where we have our mobile mammography. In the event, we have to, we don't necessarily send people to, or we try not to, the brick and mortar facilities. But in the event that we do, we have teams of people who will make sure that the patient is facilitated and directed and has transportation and has all that they need to get to that appointment. So our Project Continuity team and all of these partners work really, really hard to make this happen. This month, as you probably imagine, we've had several events, and which is great. It's good that we have this space where we're really targeting and focusing on getting people screened and getting people the care that they need. And so that's that. And then just to talk a little bit about progress. So as I mentioned earlier, our community clinical navigation team works really, really hard to make sure that once these women are identified, they can get their screening. And so to date, since the inception of this project or program, we have 191 eligibility screenings completed. And that's a large number for a team of 4, right? That's a large number for a team of 4. And they then get that information and get them ready for an appointment. So what you'll notice on this slide is we have a lot of eligibility screenings completed, right? But then we look at our numbers, and our numbers are not exactly where we would like them to be, but I would like to explain why that is. So for each patient, for each person, that could be from the time of identification and eligibility and assessment of what their needs are, that could be a total of 10 to 18 man hours that they're spending on each patient. And that is to make sure their documentation is submitted, making sure everything is, that is required from the Florida Breast Cancer and Cervical Cancer Early Detection Program is submitted, and getting the women screened, getting them scheduled for their screenings, and then also making sure that their mobile mammography service is scheduled and coordinated and facilitated. So the CCN team, like I said, they work really, really hard to get this running and to keep it operable. And Mass, Pam, she works very hard, and I definitely think she keeps the CCN team busy. We love her fire. We love her passion when it comes to breast cancer. If any of you have met her, she is definitely an amazing advocate in this space, and she's really passionate about it. But to date, we have had, out of those 191 eligibility screenings, 119 of those women were uninsured, or patients were uninsured. And then 34 screening mammograms. We've had 22 diagnostic and 17 breast ultrasounds. 57 individuals received mammograms for the first time. And 5 individuals received mammograms were less than 40 years old. So I felt those were 2 things that are very important in this work that we're doing, especially around closing the gap, especially around the care and access of our Black and brown communities of color. So, and lastly, I want to talk about the path ahead. So we know we got the data, we understand the issue, we're navigating with what the disparities are, and we're trying to respond to that. But areas that our team has talked about briefly into how do we enhance what we're doing. For one, increasing education. So what that looks like is we launched our community health worker program earlier this year, and they have been recently assigned 2 counties within our 23 county catchment area. So what that will do is allow for our community, our CHWs, to be in the community, sharing education and facilitating more conversation and access to these services that we offer. And then that goes hand in hand with the second bullet, which is expanding our reach. If we are able to get out into our 23 counties, we can then cast our net wider and make sure that those that are in our catchment area are being connected to us in some form or fashion. And then also the research and evaluation. Of course, with any program and with any project, research and evaluation is a piece that helps you understand what's working, what isn't. So we're always looking at ways to enhance the way that we collect information and how we use that information and to share and how we share. And then also the streamlining eligibility process. So one thing that we discovered and from the eligibility for the Florida Breast Cancer and Cervical Cancer Early Detection Program is the eligibility process is different in counties. So Alachua County doesn't look like Leon County and all across. So one of the things that our teams, the outreach and education and the clinical NAB team, is to think about how do we assist, right? This is a very ambitious goal, but how do we assist the Florida Department of Health and those entities, and how do we streamline this eligibility process so that it's easier not only for our navigators, but for any site, any facility, to ensure that these patients who are in need of these services are getting through the process quickly and timely. And so that is, and one more thing I'd like to mention is our community ambassadorship, something that it's in development phase as well, but this will be another opportunity for us to enhance and expand our reach, because we'll have community members being able to share information that's going on across COE and across the Cancer Center in a more informal manner. right? So it wouldn't be in the form of presentations, but these people would be in there, these community members would be people in their space, whether they're beauticians, their salon, their barbers, individuals in those spaces where they already have those connections and they already have those relationships. And that would be another aspect that we are considering for how we move ahead in this. I'd like to thank you for your time. If you are someone you know is in need of services, you are welcome to reach out to Project Continuity at 80.ufl.edu or scan the barcode on your screen or call the phone number that's listed. And I can make sure that we send this to our community art health team to be sent out in any follow-up, just in case there are any needs. Thank you for your time.
That was just so awesome. And I would say that your passion and your enthusiasm and your dedication to what you do really benefits our community. And really that's why we're here, right? We're here because whether I'm a breast surgeon or, Dr. Cousins is a, researcher, or your outreach, we're all here together to come together and to come together with all the participants here today to really learn about this. And that, I think, is the biggest and most important step is really education, right? I think that especially when we talk about, and I'm going to talk a little bit more because Tawanda Williams hasn't joined yet, so I think we'll just move into question and answers and just panelist discussions. But I think really overcoming racial disparities in breast cancer, in particularly with our African American population, non-Hispanic African American population, is a lot of education, right? Access, quality. It's kind of twofold here, where we have disparities in access, disparities in quality. Again, this whole focus on psychological well-being and readiness to accept treatment, right? Being ready and empowered and confident to accept treatment that's established and proven, but linked to almost a different biology too, right? So there's really many things we need to combat to overcome these disparities. The good thing is, and sometimes we like to look at some of the good thing is that we do see mortality going down in almost all racial and ethnic groups. And that is because over the last few decades, I do feel like we're raising awareness, we're more dedicated, we're more comfortable speaking about these things. We are really pushing that community well-being and support to really help women understand this is okay. It's okay to go through this journey. It's okay to have this diagnosis. And we can get you to that other side, that survivorship side. And we may have other challenges on the survivorship side, but let's get you there, right? Let's get you to that point. And so I think, the huge thing is again, access, right? And you going out into that community is really important. Now, I do think we've improved over the years, but we can do better. And then the quality of imaging we do, right? Or understanding when to get imaging. It's very confusing. I mean, it's even confusing for medical personnel or professionals that need to be counseling their patients on when to get imaging. There's different guidelines that recommend different things based on risk. And we at the University of Florida, we're very conservative in our screening, and we follow what's called the American College of Radiology guidelines, which is annually at 40. But we have other task force out there and societies out there that say maybe you don't need it till 45, or maybe you don't need it till 50, and maybe you don't need it every year, maybe you need it every other year. So it can be very confusing. But screening mammograms have really been the only method that have shown survival in breast cancer. And if we have a group of women that are affected with more aggressive biology or affected younger in life, or then it's really starting earlier can help that. And there have been studies that show in the African American population, if we do follow and start earlier at 40, we're going to improve mortality from breast cancer. Other thing is quality of screenings, right? So where are patients getting screenings, right? I would say over the years, we've had a lot of advancements in how we screen for breast cancer. And we use different technologies, but those technologies aren't universal across the country, right? So maybe the screening we use may not be as optimal. So really educating about and helping, having these liaisons, having people in our community to help get to the right places to get good screening is really important. And then really understanding biology and having dedicated researchers really trying to advance understanding of biology, and not only just biology of the tumor, but the environment, the microenvironment, right? So if we have a body that's stressed, right, that's going to be more prone to cardiovascular problems after treatment, but may also be less susceptible to treatment of the standard of care, big clinical trial drugs may not work as well in certain microenvironments or what the body's made of. And maybe there are some genetic differences in racial groups, right? So we definitely have a lot of passion at UF, a really great team focused in on trying to understand disparities and change and differences in biology. But I think the most important thing is why we're here today. And that is truly education, right? Education of our community, awareness of our community, of these challenges we have, resources we have to overcome them, dedicated experts here at UF dedicating their life to overcome them, and people in our community that are really trying to be available to help our community understand and get access to care. So I just think everybody a part of this town hall today is just fantastic, and really has been such a pleasure to listen to and be a part of. So I'm going to stop talking because I do talk a lot, and see if there's any questions out there. I know that some of them have been answered, and I may ask just in case people can't read the responses, but maybe I'll have Dr. Cousins just kind of go over one of the first questions was equating really spiritual well-being with a specific belief in a God figure. So Dr. Cousins, I'll have you just talk about your response to that.
Yes, of course. I get that question a lot because, we may have individuals, and that is completely okay, who may not believe in God, but they do believe in other sources that are outside of themselves. It could be whatever spirituality that they're believing in. And so when Ms. Bloodworth asked that question in the chat, I kind of gave the definition of what spiritual well-being really is. And it's just expounding on this sense of purpose and meaning. And that's one of the reasons why I love talking about, mindfulness, meditation, and spirituality, because it kind of centers you and gives you that sense of purpose. And so a lot of times, the feeling that you get may not be from God or other religious activities. It just depends on what you believe in and what makes you happy.
That's great. And I'm seeing here that I believe we have our last panelist that has just joined. Welcome.
Hello.
So we're going to just hold off a little bit on this Q&A session and move on to hear another amazing speaker today. So Tawanda, do you mind introducing yourself? And then I would just say you could go ahead and get started. Welcome.
Hello. My apologies. I had the times mixed up this morning. I am Tawanda
We're just glad
Williams.
you're here.
Yes. Thank you. I'm Tawanda Williams. I'm the executive director for Blossoming Butterfly. We're a nonprofit organization with 6 those diagnosed with breast, uterine, and ovarian cancer while going through treatment.
Great. Well, welcome. And if there's anything else you'd like to say or present, you're welcome to do that. Otherwise, we can go back to doing some of the question and answers.
Yes, I'd like to share something about one of the services that we offer.
Great.
Yes, ma'am. So I'd like to share my screen.
Naomi, can you help share her screen? I'm not sure if you can on your end.
Yes, just 1 second.
Okay, great.
Okay.
Okay, you should be able to share your screen.
Okay. So we're just going to share briefly who we are. I'm going to move past some of the slides in the beginning and just talk about breast therapy, but I'd like to share a quick video.
Naomi, is there anything I can do on my end?
Tawanda, if you're able to share your screen, I think that would work
Yes,
best.
I'm not, it's saying that it's sharing. I apologize.
Sometimes when you push
It's,
share screen, then you choose exactly the specific.
yes,
We needed
yes,
someone
ma'am.
on here to do our Zoom 101.
Okay. Yes, ma'am.
We could all use that,
Aside from that,
right?
I'll just talk about our breast therapy that we offer. No worries.
Perfect.
So one of the main things that our CEO Nicole Miller she really likes to focus on is uplifting and motivating within our organization. And so we all understand that cancer can be something that is very scary, is very frightening. I too myself, I'm a cancer survivor. I'm a renal cancer survivor. So I've been on both, sides of it, both in patient care and as a patient. And so it can be very scary. So with Blossoming Butterfly, we understand that there's a lot that our butterflies are going through and needing, financial assistance and everything. But there's also a psychosocial piece that comes along with that a lot of people may not be aware of or may not think about unless it's affected them personally. And so with breast therapy, it's not just for our butterflies, it's also for caregivers and it's for children and anyone that's involved with, their journeys. And so during breast therapy, we don't talk about the big C word. We focus on uplifting and motivating, but within that space, it allows everyone that's in person or via Zoom, it allows everyone to feel connected, and it's a safe space for you to be able to open up. Even myself, when I was going through, everything, when you're a patient, sometimes you don't want to burden your caregivers or, how you may be feeling emotionally, or you may feel, but in this space, it's a safe space to open up. And in going through cancer, statistics have shown that patients who are going through cancer treatment, depression, anxiety, sometimes addiction comes along with it. So there's so many other pieces that comes along with just needing financial assistance or something tangible. So Blossoming Butterfly, we aim to try and provide that safe space for our butterflies, along with everyone who's connected to our butterflies.
That's wonderful. And how do our community members get a hold of you? How do they have easy access to Blossoming Butterflies? And
yes, we have a website, blossomingbutterflyinc.org. And you may also contact us, via our social media sites. And we also have an email. But like I said, blossomingbutterflyinc.org is our website, where we have all of our events announced and everything that is going on throughout our community. We like to stay engaged throughout our community as well.
Great. That is amazing. Thank you for all you do and for being a part of our panel today. Again, this
Thank
is
you for
just
having me.
another kind of focus, and again, really a push to coming together as a community to really promote not only understanding and importance on and feeling comfortable and confident in taking care of yourself. And if you feel something abnormal or you have never had your mammogram before, it's okay. We don't want to wait any longer. We want to just move forward and start. I always, I'm a breast cancer surgeon, but my mom, it was about 5 years and she finally admitted to me she wasn't getting her mammogram. And I said, you can't do this to me. Well, you can't, but you have to get it because if it's there, we want to know. We don't want to miss it.
Right.
We have to take care of it. If we miss it,
right.
we can't take care of it. So don't be scared, right? Don't be scared. And
then again, there's that psychosocial piece. Fear sets in, and
yes. And so we can't be scared. We have to be, again, we have to be super women, right? We have to be powerful. We have to take care of ourselves so we can take care of others. We can't take care of others if we don't take care of ourselves. And so really to have that strength to move forward with the journey, and then have the strength and the support throughout the journey, and then have the strength and support on the back end with so many wonderful people on this panel today. So I think that's really one of the most important things. So I will sneak over again to the question and answer. If any of the panelists would like to speak a little bit more, go ahead, but I'm going to move over here. It looks like there are participants that are very interested in learning more about the community health program and how maybe individual community members can become engaged. And so Latrina, can you touch on if that's an easy process and doable?
Sure. We would love to have conversations with any of those interested in our community health worker program. I will put my email in the chat and you're welcome to reach out. But it's a very streamlined process of making sure that we have, of course, some positions and things like that. I have to assess where we are with that. But yeah, I'm more than welcome to even our community, our ambassadorship that I mentioned as well. For any of those on here that are interested in that, wanting to learn more, please feel free to send me an email and I can get you some information over. I'm going to put that in the chat now.
Okay, great. The next thing I think we'll just keep you going, Latrina, is how do we, who is able to get a mammogram on a mobile mammography vehicle? How does insurance play a role in that?
Right. So the Florida Breast and Cervical Cancer Early Detection Program has a very, set standard and eligibility process. So we work closely with them and those women who are uninsured. I know that there are people who are underinsured, very loose term, but there's real, eligibility criteria that is attached to that. And so for anyone that is wanting to know what their eligibility, if they're eligible for those services, you're welcome to reach out to our community clinical navigation team. And I can have that sent, put that in the chat as well, or we can send it out, Naomi, in a follow-up. But that would be the initial step to find out who is eligible, speaking to our community clinical navigation team, and they will start that process.
Okay, great. Dr. Cousin, I'll address the next chat question with you. If you would like my help, I'm happy to help too. So the question is really focused on benefits of hormone replacement therapy and how hormone replacement therapy really helps women feel really good and enhance their livelihood after menopause. And it's sad that we have to take that away in terms of breast cancer risk. So pretty much open end in terms of the role for hormone replacement therapy after menopause, how it affects our quality of life, and I guess any information on who we need to worry about saying can or can't use it.
And so, yeah, and she also mentioned, seeing more studies done on the benefit of hormone replacement therapy. And actually, most of my work has been looking at the impact of chemotherapy and radiation. I never thought to just focus on hormone replacement therapy. That's definitely a space to consider with our breast cancer survivors. Yeah. In some women, it can be protective, and there's also pros and cons from it. And so I'll let you, Dr. Spiegel, talk a little bit more about that as you're in the field more often than I am.
Yeah, no. So I would say that I think there's two things to be thinking about here. One is after treatment, and the treatments that we use for breast cancer do, in many women, we need to give treatments to decrease estrogen level as low as possible. And that's those hormonally driven breast cancers. And those are the majority of breast cancers that affect all women. So the majority of cancers being diagnosed are going to be hormonally driven. The biggest risk factors for breast cancer are really us being women, because we have hormones. And those hormones affect our breast tissue. We have more breast tissue than most men do. And so 99% of breast cancers are going to occur in women. And the two biggest risk factors are age. As we get older, those hormones affect our breast tissue longer. And obviously being a woman, having more breast tissue. So as we get older. So the majority of breast cancers are going to have some form of estrogen or progesterone. Those are the two main hormones we look at expressed. And so when we get a diagnosis of breast cancer, we really want to starve those tumor cells of any fuel to continue to grow, right? We need to deplete as much as possible that estrogen in our body so that we can decrease our risk of that tumor ever coming back, whether it's in the breast, whether it's development of tumor, a brand new cancer, second cancer, unrelated to the first cancer on the opposite breast, or preventing spread to other parts of the body. And that's really the only time we can't cure breast cancer. We can cure breast cancer when it's even in the lymph nodes, right? So, it's really scary to get a breast cancer diagnosis, but if you look at, the data, when women get diagnosed with breast cancer, you look at all comers, we have over 90% 5-year survival. When you look at tumors that are just in the breast tissue and haven't spread to the lymph nodes, it's 99% survival. If you look at tumors that are in the lymph nodes, it's still 86% survival. I mean, these numbers are really great. And that's why we really want to push women to get detected and diagnosed early rather than wait. But the majority of these tumors are going to be hormonally driven. And so we don't want to be giving hormone replacement therapy to women diagnosed with hormonally driven breast cancer, because we're just giving fuel to the fire. We don't want to do that. And it does affect quality of life. And if you look at statistics, 30% of women are non-compliant. They don't want to take it, right? So actually 30% of women don't do it. And what I tell patients is that every woman is affected differently by these medicines. I have women that come in and they're like, I don't know, I don't even realize I'm on it. And I have other women that it just ruins their day-to-day quality of life. And that is when we really need to say, okay, then you have to look at overall life risk benefit, right? What you need to get up every day. You need to get your clothes on every day. You need to go to work every day. If you work, you need to be with your family every day. You need to do all the things every single day, right? If you can't do that because you're protecting yourself against your breast cancer, well, then shoot, maybe the risk of it maybe coming back is okay if your quality of life to get out of bed every day and do work every day and be happy every day. So really try to find other avenues before we stop these medicines, but try to find other avenues to really enhance your life and overcome the side effects of the medicines before we stop them. But ultimately, if nothing's working and you're miserable every day, then the risk benefit reward is not there anymore. Now, if you take a look at women that are taking hormone replacement therapy just because they go through menopause, they do not have a breast cancer diagnosis. It's a different group of women, right? And so when you have women, we go through menopause, most of us go through menopause around age 50. All right. So around age 50, we're starting to lose our estrogen. Our ovaries don't work anymore. And so that can affect our quality of life. And so there are hormone replacement therapies to take to give you back that estrogen. And estrogen is good for other things. It increases risk for breast cancer, but it's going to be good for your heart, your cardiovascular system. And so really what we think about is look at overall risk, right? Every woman also is at a different level of risk for breast cancer. Statistics show us that 1 in 8 women will be diagnosed with breast cancer. Average woman in the general population is 13%. But the reality is that some women are 8% and some women are 45%, right? So if you want to take hormone replacement therapy because you're going through a difficult menopause, think about your overall baseline risk. And this is something you can discuss with your provider. So if you have 10 family members with breast cancer, all diagnosed at 50, well, maybe you don't want to take hormone replacement therapy, right? Because that's real, right? Your risk is going to be real. But if you have 0 family members diagnosed with breast cancer and your quality of life is really poor and your risk at 50 is actually only maybe 8%, then taking that hormone replacement therapy that's going to increase your risk a little bit is not as risky. All right. So really, I think understanding baseline risk helps us understand, is it safe to do hormone replacement therapy? And also hormone replacement therapy is different, right? So the big thing, just to kind of simplify it, is there's hormone replacement therapy that has estrogens and progesterones, and there's hormone replacement therapy that only has estrogens. And the safety to do one or the other is really based on whether you have a uterus that's there or not. All right. Because if you have a intact uterus, that means you haven't had a hysterectomy, then you need the progesterone to protect the uterus from the estrogen. Whereas if you don't have the uterus anymore, you can take estrogen alone. And when you look at these big hormone replacement therapy studies, it shows the combination. So when you have to do the estrogen progesterone, that's when the risk is higher than when you're just doing estrogen alone. So it's also the composition of the hormone replacement therapy that you're taking. So a lot of things to think about, very important to talk to your provider, but I think it's really based on a risk benefit reward. Like anything in life, we have to be happy every day, right? And so sometimes we take that little extra risk if we need to. And even with my patients with breast cancer, sometimes they stop those anti-estrogen pills. So they're not hormone replacement, they're anti-estrogen pills. When we treat breast cancer, sometimes they have to stop that because, again, it's a risk benefit reward and their quality of life is so poor. And that is okay. It's just what everybody's comfortable with their own individual risk. So I'll just touch on one other thing is in terms of mammography, there's a question in there that was mammography is suggested for women over the age of 40 to get regular mammograms. Yes, we agree with that. We agree. We follow the American College of Radiology guidelines here at UF, and that is annual mammograms starting at age 40. And it, depending on risk, you can even be higher risk. Sometimes in our patients that have strong family histories, we do genetic testing. We see that there might be a genetic link to breast cancer, or you have a genetic link that will put you at very high risk for breast cancer. Sometimes we start mammograms at 30, right? And we start what's called a breast MRI at 25, right? So really understanding your family and cancers in the family, breast, ovarian, pancreas, prostate, all these cancers go together. Really understanding that will help your doctor also educate you or get you to our high risk clinic to say, hey, we got to be doing more than mammograms at 40, right? This is the average population. And then what about men? All right. So we never want to leave men out of the picture. But again, only 1% of breast cancer occurs in men. The biggest risk is when we look at men that are diagnosed with breast cancer, many times there could be a genetic link to it. Or if a man ever gets, let's say, mom gets diagnosed with a breast cancer gene, BRCA gene. Those are the most common ones. Breast cancer associated genes 1 and 2. BRCA 1 and 2 are the most common. And the man gets tested and they're positive. Really, this is the group of men that we screen. Or I would say is becoming, we're starting to be less sexist, right? We're starting to say, what about men? So we want to think about men. So some of the newer guidelines, and there's not a lot of data with it because the incidence is so low, right? We get good data by numbers, right? 300,000 women are going to be diagnosed with breast cancer this year. That's scary. But that also means we have really good data to guide treatments because we have high numbers. Men, only this year will be maybe 300 men. See the difference? Huge difference in incidence. Or maybe 3,000, it's 1%. So, but it's so much lower. So the data in terms of the benefits aren't there. But the one group of men that we do say could benefit from screening is going to be the carriers, the BRCA carriers, right? So those BRCA carriers in the men that actually have a problem called gynecomastia. So what gynecomastia is overgrowth of breast tissue. And some men have that. They have overgrowth of breast tissue. All right. So in those men that have overgrowth of breast tissue, we say we can start mammograms on them, typically 10 years younger than the youngest male diagnosed in the family or at age 50. Okay. And that's what the new national guidelines are. So men can get screened, but typically they're going to be the men that are genetic carriers. But still, the incidence of breast cancer in men is so much lower. But we need to be aware. We need to be aware and not be sexist as well. Okay, so let's see. I know we're about 9 minutes over. So I'm sure some people will need to sneak off, but I'm happy if anybody wants to sneak in another question in there, definitely happy to put one more question out to the panel. If not, we will, I think we've really hopefully hit home on a lot of really important topics about breast cancer and really encourage some of our listeners today to kind of empower them about understanding breast cancer, empowering them or giving them courage to seek care, undergo treatment, and to access the resources we have here today. So, all right, I don't see any other questions, so we'll go ahead and finish the town hall questions here. And thank you all for attending, and thank you to our panelists for taking their time out of their day to provide us with excellent education. Have a good day.